Welcome to the Pelvic Health Podcast with Anthony Lowe, the physio detective, and Laurie Fauna, the physio down there. Together we interview leading physiotherapists devoted to women's and men's pelvic health, answer your questions, and share our thoughts. Remember our disclaimer. The materials and content within this podcast are intended as general information and for entertainment purposes only, and are not to be considered a substitute for professional medical advice, diagnosis, or treatment. Now, grab your favorite beverage, sit back, and enjoy the show.
Using rectal balloons in physiotherapy. So this little tidbit is just Susan's very small amount of information on some rectal balloon therapy in physiotherapy. So enjoy.
Talking about constipation or visceral hypersensitivity, one of the other things we have, in our arsenal as physios is the rectal balloons. Those are great gadgets. They're balloons on the end of a tube that you can fill up. You can inflate and deflate with air, so you don't have to put any liquid in. I always put a condom over it so that nothing ever happens inside. The end of the condom is always hanging out. So you have a nice little sack, and it's very hygienic, and the condom comes in this little package, and you put it on and inflate. This is the coolest thing about the rectal balloons is helping people learn to expel them. And when Anthony was talking about the psychosocial, the sensory piece of everything and the signals and all of that, there is nothing like the sensory experience you get from a rectal balloon, because literally you are pooping out the balloon. You can put the balloon in, you can inflate it a little bit. It's no different than a manometry test where in the physician's office, they will inflate the balloon up to 50 milliliters, and the expectation is that somebody should be able to get rid of that. They should be able to evacuate that. And then they take all kinds of pictures and look at what the pelvic floor is doing and everything, and that's when they'll come up with outlet obstruction, which is pelvic floor dyssynergia, or the pelvic floor is failing to do its end of things once the pressure builds in the rectum and it's time to evacuate. They'll look at that with a 50 milliliter balloon. Well, as physios, we can put it up to 20 milliliters or even 10 if somebody's really sensitive or afraid. And we can work with them. We get them up into a sitting position and over a bedside commode. I actually have a regular physio table that has a face where people put their face in. I'll put a chair.
Oh, their poor faces.
And wait for it. I put a chair up on one end so that, it doesn't break or fall down, because you're never supposed to sit on that part where the head goes. And I'll take a Chuck's pack and cut a slit in it and put it right over the faceplate. So they're sitting, everything's covered, everything's wonderful, and we have a bucket underneath, and we'll use the balloon. And they literally can work on, in a seated posture, in a good posture, feeling, and for many of them, they've never felt that before. This is what normal pooping should feel like, because you can assist it. You can help pull everything out as they're actually breathing and keeping their pelvic floor relaxed and working on the top-down type issues that they need to work on to get things to happen and change. And sometimes for many people, once they feel that the right way, then their brain takes over. It's like, we know how to do this. We can do this. We're good. This is it. And they do very, very well.
Do you ever fill it with water, or do you always do air?
I always do air. I don't think the balloons that we have available to us in the States, I don't know anybody who puts water into them. I just do air. It's easy. You can do air, you can inflate, you can deflate. It's very fast. It's not messy at all. For people with hypersensitivity, sometimes you can work on decreasing their response to an increase of inflation. So you can work easy that way.
Which I find is similar to pain.
Yes, exactly.
Yes.
Exactly. You treat sensitivity or that urgency frequency the same way that you would a pain response. It's a central sensitization over time.
But if someone is hyposensitive, that's where I get lost a little bit of the times with the balloons. You're like, what cues am I to use to get you to feel something that you can't feel?
Right. So oftentimes people are hyposensitive for two reasons. Number one, they either have a large rectum, because they've used it as a storage vesicle and it's not for a long period of time. The other reason is that they've quit listening to their call to go. And they started doing that somewhere along the line. The worst people at risk are going to be our healthcare providers and teachers who cannot leave the classroom. So they've learned to suppress the urge to go for many, many, many years. So they just quit listening to it. So guess what? The brain's going to give you something else to listen to at some point, right? Oftentimes they'll tell me, I know that I should go to the bathroom, but I don't really feel like I ever need to go. They're really hyposensitive. So oftentimes what you can do with the balloons is you can put them in there. You can get them rather large. You can also slide them up in a little bit higher so that you hit a different part of the rectum. But one of the things that I will ask people to do is I begin to inflate the balloon, and I get it inflated to a good amount that I think somewhere over 120 milliliters.
Yeah, that's what I was thinking.
I start asking them to tell me about anywhere else in their body are they feeling something. Because oftentimes what they'll say is, oh, well, yeah, I've got like a mild cramp in my tummy. There's your call to go. That's the thing. So I'll capitalize on that. When you begin to feel, or sometimes people will say, yeah, I feel like it's hard to swallow. They come up with all kinds of things. But remember, the system goes from our lips to our anus. So you can trigger all kinds of things within that system at different points of that system. And we have some good research that'll show that you can actually treat visceral hypersensitivity down at the rectal area. Because as soon as you begin to fill the balloon, they may have a lot of visceral hypersensitivity, which is different than hypo. And you can get them to downtrain that and not have that firing off response every time they need to go to the bathroom. The same thing for hypo. Where is it? It's going to trigger something somewhere. Where is it? And they can begin to feel that, and that's your call. That's when it's time for you to go. After dinner, when you feel that, we got to capture that gastric colic reflex within 30 minutes of distending the stomach. That's your call. That's when you feel that's it. You need to drop everything and go pay attention to that and get yourself ready to go to the bathroom.
Wow, that's taking kinesthetic learning to the next level, isn't it?
It is, right?
And just because, and I think your later explanations have explained it for me, you're putting the balloon in deflated and then you're pumping it up, is that right?
Yeah. Oh, yeah, you absolutely put the balloon in deflated.
Okay, because I'm just thinking...
Well, especially if you're pumping the balloon up to 150 mils, you're not going to get it in.
We don't want to be the threat they're protected against, Anthony.
I think the prison defense is coming on right now.
You put it in absolutely deflated, and then you can start really low, and you can kind of get a sense of, do you feel I'm inflating the balloon now? You have to keep the tube still, because if you wiggle the tube around, they feel that, and they think that's the balloon. Because remember, where we have most of our sensation and pain response is going to be at the external anal sphincter. The rectum doesn't have nociceptive receptors, right? It has pressure receptors. So we're looking for pressure and for that visceral response and not a somatic response.
Wow. I'm still trying to get used to the idea that things go up inside that way. Musculoskeletal physio all the way. Still avoiding my first prostate check.
You have to think that the straw that the balloon is attached to, the tube, is a third of the size of my index finger.
Right.
They've already had my index finger.
Right. Of course.
Inside.
For the examination.
Yeah, exactly. And that's another thing. You never stick balloons where you haven't been before. You just don't. You need to know where you're going and, what the shape of their puborectalis and anal sphincter and everything is and all of that. And then when you guide the balloon in, it's very, very easy and it doesn't bother them nearly as much as, again, where they have the most sensation and certainly the pain, the nociceptive receptors are going to be around the external anal sphincter. Inside, they don't. It's just pressure. And what we're trying to do with that is either increase or decrease the intrarectal pressure to move the balloon or to keep the balloon there for people who are maybe having a complete, what I consider fecal incontinence is a complete loss of a well-formed stool. I don't consider fecal incontinence diarrheal. That's a different subcategory of it. But when people are losing like a large stool and they don't know, then we've got a real complete problem with the whole external anal sphincter area and its ability to hold against that. We should be able to delay a bowel movement long enough to get where we need to go, or because it just may not be convenient at all. If it's time to run from the tiger, we need to be able to have the system that can handle that. I think that gets into that hyposensitivity you were talking about, Lori, like, how do I know when I need to go to the bathroom before it happens? Because all of a sudden, I maybe begin to feel it when it's at my anus, and then all of a sudden it's out. I need to know ahead of time. Well, they're missing a call somewhere up the line.
Yeah.
And so that's where they can get that, and working with that balloon can help them identify what are those visceral cues. Because maybe when I feel it here in my tummy, I've got 5 minutes to get to the bathroom before it is ready to come out. And then you can also, with the coolest thing with the balloon is getting into more musculoskeletal, Anthony, is you can actually fill the balloon up and you can, have it's in the rectum. Then you can tug and pull on the balloon and have them actually lift their pelvic floor and work against that. So they can work to stop stool coming out, and you can give them the strength and coordination to do it. And it's in real time with real sensory stuff that feels just like a real stool rather than just squeezing their muscle over on the side. Talk about something becoming very functional. And then you can have them stand up and do it, right? So they don't have to always be laying down. They can stand up. They can, and you can tug on the tube a little bit, and they can have to lift their pelvic floor, and you can keep them from cheek squeezing or tightening up their abs too much. They can really get into, how do I really when I feel this and I know that I need to go and I've got to make it to the bathroom. So you can give them that work, especially if they've got some insufficiency in their pelvic floor, puborectalis, or their external anal sphincter.
That's right. If they're losing it, they're not usually lying down.
Right.
Maybe, but usually they're somewhere trying to get to the toilet.
Usually they're up on their feet trying to get to a bathroom, or they're walking, or they're bending over and something happens. Yeah.
Wow. I really appreciate pelvic floor physiotherapists. That's it for this episode. If you have any questions for us or any of our guests, be sure to ask them on this episode's page at physiodetective.com/pelvic health podcast or at lauriefauna.com. Thanks for listening, and please join us on the next episode of the Pelvic Health Podcast.